Okay, good morning. Hopefully you guys can hear me okay. We're going to talk about some fibrohistiocytic lesions today, and we have quite a few of them. So it's kind of a survey, if you will, just to kind of go through and show you all the various things that basically can give you neoplasms or proliferations due to fibroblast and histiocytes, some benign, some malignant. And the most common one that we see, and again, remember, these are fibroblast and histiocytes. So this is not epithelial, it's not adnexal, anything like that. We're talking about dermal-based cells. So if you're looking in the dermis, things that live in the dermis, fibroblasts live there, histiocytes live there, other inflammatory cells migrating in and out of the dermis. We have blood vessels and things like that, but we're looking mainly here today at fibroblasts and histiocytes. And the most common of these is basically scar. You injure somebody, they get a scar, they get proliferation of their histiocytes and fibroblasts. And sometimes if it forms a little nodular aggregation like here, basically dermatofibroma. Okay, that's the most common benign. It's really not a neoplasm, it's really an epithelial, a non-epithelial proliferation of fibroblasts and histiocytes with dilated blood vessels. And there are a lot of different variants of dermatofibroma. There's probably about 6 or 7 variations on the theme that you need to know about. This is kind of the classic common type. This could have been precipitated by trauma, maybe a bug bite, and you get a secondary dermatofibroma that develops, maybe a ruptured hair follicle, something like that. Pretty common post-traumatic injury. You can see there's some crust up here. So this might have been precipitated by a bite. And you can see all the fibroblasts and histiocytes in the dermis. It's very common to get this so-called collagen trapping, keloidal collagen bundles. They look like the collagen bundles of a keloid here. It's not really a keloid, but it's keloidal. And you get this, some people call this a donut sign. It's commonly seen at the periphery of a dermatofibroma. So that's one variant. That's just the good old-fashioned common dermatofibroma that you see secondary to trauma. Occasionally, you get this form, where you get this prominent proliferation of all of these cells that have all of these stellate, bizarre-shaped fibroblasts. In some areas, you may see hemosiderin deposition. You get a lot of dilated blood vessels. This is a cellular dermatofibroma. And these lesions tend to occur on the lower parts of the body near the ankle of younger individuals, often women, interestingly enough. And it actually has been referred to as the ankle type dermatofibroma, which is sort of an interesting variant, if you will. It's still benign. You can notice at low magnification, even though it's pretty big, it's really very symmetrical. It's very well circumscribed. It's basically, they excised this, just basically came out in one piece. Not anything to worry about. Not overcall this as a melanoma. Don't overcall it as anything malignant, and it's totally benign. It's just a variant of a dermatofibroma. So the key to the diagnosis is looking at this power as well, seeing the type of cells that we're looking at here. Most of these are fibroblasts and histiocytes, and the fibroblasts tend to get pretty large. They can become somewhat irregular and angulated, if you will. It's not uncommon to see extravasated erythrocytes in a lot of these, and you can also get a lot of hemosiderin deposition. Occasionally get some mitotic figures. You don't get a lot of mitoses in these, but here's one here. That doesn't mean that it's malignant. So again, you have to look at all the other features of the lesion. And then if you look at the periphery, you may see that collagen trapping again, that keloidal collagen bundle surrounded by these fibroblast histiocytes like we saw in the other lesions. So nice example here of a cellular dermatofibroma. Now, just to mention a couple of other types of dermatofibromas, there's a dermatofibroma with monster cells. We get these very large cells that are probably histiocytes, and they're multinucleated, and they can look kind of bizarre and almost look like malignant in some ways, but they're not really malignant. There's a type that can have a lot of osteoclast-like giant cells. There's a type that can have a lot of lipid in them that can almost look like a xanthoma. There's a dermatofibroma-like proliferation that can occur on the head and neck area, especially on the face. We often just call benign fibrous histiocytoma. So think of that as a dermatofibroma that occurs off the trunk or extremity, occurs on the face. In that situation. But it's the same type of process. It's benign proliferation of fibroblast and histiocytes. And a couple of things about dermatofibroma, sometimes you can get overlying epithelial hyperplasia with basaloid proliferation that can simulate a basal cell carcinoma. So if you just get a superficial shave biopsy of one of these, you may actually get back an erroneous diagnosis of a basal cell. So it's analogous to the pseudoepitheliomatous hyperplasia that you can see overlying the epithelium, overlying, say, a granular cell tumor or overlying an infectious disease. So you have to remember that sometimes if you get a superficial sample of one of these things, you can get an erroneous diagnosis because of these epithelial proliferations that occur overlying the dermal process. Okay, this is a different animal here, and this is a dermatofibrosarcoma protuberans. Now notice at low magnification, they've taken a punch biopsy or maybe an incisional biopsy. They didn't get the whole thing. And notice that it goes from side to side and top to the bottom. It's also got this really nice honeycomb-like infiltration in the subcutaneous fat. We'll talk about that in a minute. Now, a lot of people say that the differential diagnosis of dermatofibroma is dermatofibrosarcoma protuberans, but it really isn't the differential diagnosis of DFSP. They really don't look the same under the microscope. If you did a shave biopsy of this, maybe there's some of this that looks a little bit similar, but it actually is not really, as you look at this higher magnification view here, there is not the angulated, jagged, large, irregular fibroblast and histiocytes in a DFSP. The cells tend to be more smooth. They're more of these elongated, almost S-shaped like nuclei. It almost looks a little bit more like a neural neoplasm than it really looks like a fibrohistiocytic neoplasm. So it's really a myth, if you will, that DFSP and dermatofibroma really look similar. In my opinion, in my experience, they really look closer to neural neoplasms. I've seen far more of these misdiagnosed as neurofibroma than I have as dermatofibroma. And almost never see dermatofibroma that gets called DFSP. They just really don't look that much alike, in my opinion. And the other thing is, if you look at the involvement of subcutaneous fat, I mean, this is really quite characteristic. It replaces the subcutaneous fat. So here, much of the fat has been replaced by the spindle cell proliferation here. You can see in many cases, you'll see that so-called storiform or basket weave pattern of the fascicles of the cells that interweave, and you get a little bit of sense of that here. You can see that there's maybe this fascicle here is kind of going this way, and this one's kind of coming out at us. It's cutting in cross section. So that's kind of the storiform pattern that we talk about. But in my experience, if you really get this fat involved, where you get this honeycomb diffuse involved with this intercalation of these spindle cells between the individual lipocytes, that is really pretty classic for DFSP. So you really, this actually is a little bit of that collagen trapping that's a little bit less common in DFSP than it is in dermatofibroma, but it's not, again, that's not a criterion for the diagnosis of either of the two. So you can sometimes see it in both, but you never see this pattern in dermatofibroma. Just doesn't happen. You don't get this diffuse involvement of the septa, the subcutaneous fats. Just notice this is dissecting right down to the septa here, and then all these spindle-shaped cells that are between among these individual lipocytes in the subcutis, like you see here. That's pathognomonic virtually for DFSP. Never ever see that in dermatofibroma. If you get fat involvement in dermatofibroma, it's usually kind of a jagged sort of individual little, the same type of cells we saw earlier that are forming these little sort of tooth-like jagged invaginations into the fat, but not this diffuse involvement that goes all the way through the fat. If you see something like this, it's virtually pathognomonic for DFSP. There's nothing else really that'll do this. And if you want to do immunoperoxidase stains, obviously you can confirm the diagnosis with CD34. It's diffuse, stains the lesion in a diffuse, very, very dark pattern all the way through, side to side, top to bottom. If the differential diagnosis is a neural neoplasm, like a neurofibroma, you get what's called a thumbprint pattern of staining with CD34. So you get some positive staining with CD34, but it's sort of just focal and diffuse, and some people say it looks almost like a thumbprint. It's not this very dense, dark, diffuse staining pattern that you get with CD34 when you're staining DFSP. So again, the main differential diagnosis you're going to have is between a neural neoplasm and this not a dermatofibroma. And of course, the stain for a dermatofibroma is a factor 13A stain, which is strongly positive in that lesion. So nice example of DFSP. Now, one other thing that the board is likely to ask you, and I recommend that you go back and study it, is the translocation of platelet-derived growth factor beta with the COL-A mutation. There's basically, you often get a ring chromosome that gets formed there, where you get this translocation and fusion. And then basically what happens is this platelet-derived growth factor gets turned on when you get this fusion protein, this fusion and genetic fusion, and then it leads to the proliferation of all these cells here. And this lesion will also respond nicely to Gleevec therapy. You put them on Gleevec, the lesion can actually be shrunk down prior to the excision in many cases, so it can shrink it down. Then you do Mohs surgery, whatever you do to kind of improve the, you treat the lesion, actually and decrease the size of the excision. Now, this is a good example of what you really don't want to do in DFSP, and this is where we get a shave biopsy. This is really, I'm glad we put this in here, because this is really sort of what you don't want to do. And this is where you can be prone to missing the diagnosis. This is where you can easily get something like this, and it looks like a neurofibroma, maybe it looks like a, maybe even a desmoplastic melanocytic lesion. It's got these spindle-shaped cells here with this kind of myxoid stroma, and it looks almost like a myxoid neurofibroma, if you will. There's a mast cell in here. And again, dermatofibrous protuberans can give you there's a variant that can be myxoid, and it can look like a neurofibroma. And I've seen these lesions misdiagnosis of these as neurofibroma, as have I seen that with desmoplastic malignant melanoma. So it's a bad practice to shave a soft tissue neoplasm. I always say in my lectures that I give that whenever dermatologists and soft tissue neoplasms intersect, it's often not a good outcome. It's like a car wreck. And the reason is that dermatologists don't see that many soft tissue neoplasms. They don't think about them. They do shave biopsies of them, and then they shave the surface, and then they get back a diagnosis of neurofibroma or scar or something like that. And then it sits there for another year or two and finally gets a huge, giant, deep-seated process, and then it gets sampled by a plastic surgeon or something, and then you get the diagnosis, and then it's too late, or it's a much more bigger surgery and lawsuits and everything else. So always take a deep incisional saucerization, some kind of larger biopsy. And I would, if you're not sure what it is and it looks kind of weird and you don't take a giant biopsy because maybe you don't have time or something, send a picture, send a description. Don't just send a shave and say nub, neoplasm of certain behavior, because you're liable to get back some generic diagnosis and then ends up in a lawsuit. So don't do that. It's not best practice. It's dangerous, and it can lead to all sorts of complications. So this was a shave biopsy of a myxoid dermatofibrosarcoma protuberans. I don't know the story and how this was diagnosed or the history of it, but this is what they look like when you see them under the microscope. They don't really give you the classic storiform pattern. They give you this sort of diffuse proliferation of these sort of delicate, not really very atypical spindle cells with the myxoid stroma, and it's a little bit more cellular than in classic neurofibroma. And it actually, in this case, was the shave biopsy of the surface of a myxoid DFSP. So just remember that can be a dangerous diagnosis, and you want to make sure that you keep that in mind. So that actually was diagnosed appropriately. Now here's another DFSP. Now this one's kind of interesting because it's got another finding in it that we occasionally see in these lesions. And notice this one's got the nice storiform pattern here, the spindle-shaped cells that are forming these fascicles and interweave. So storiform means like basket weave. That's what it means. It's not like a story in a building or a fairy tale story. It means kind of like that spindle cell pattern in weaving. But it also has melanocytes in it. So notice these dark pigmented melanocytes. So whenever you see what looks like a dermatofibrosarcoma protuberans with a melanocytic component, that's called a Bednar tumor. It's actually pronounced Bednar. And it's a, I believe, Turkish dermatopathologist or pathologist that originally described this. So this is basically kind of a combination of a DFSP plus a melanocytic component. It's not really a melanocytic lesion. It just has these melanocytes in them, and they kind of look like these dendritic melanocytes with these sort of thick dendrites here. And the melanocytes are not atypical. It's not melanoma arising in association with this. It's not a desmoplastic melanoma. It's basically just a DFSP with a component of a melanocytic element to it. And here you see the honeycomb involvement of the subcutaneous fat again. If you stain these, strongly positive once again for CD34, and you stain the melanocytes, they'll stain positively with SOX10 or with S100 proteins. So basically, this is just kind of a combination of DFSP plus a melanocytic element to it. Just kind of remember that one. Okay, we're moving on now to a malignant neoplasm, and this is the most common cutaneous malignant fibrohistiocytic neoplasm we see in dermatology and dermatopathology. And this is atypical fibroxanthoma. And again, this is a malignant neoplasm of fibroblast and histiocytes. So it's a shaved biopsy. These lesions usually are thought to be a basal cell carcinoma or squamous cell carcinoma clinically. Dermatologists extremely rarely diagnose this clinically. Once again, we're not really taught much about it in our residency program. Maybe if you have a Mohs surgeon in your program that knows about these, you might give a lecture or two on it. But most of the time, we're taught to think about, rule out basal cell, rule out squamous cell, rule out melanoma. And occasionally you shave biopsy of something, and it's none of those. And when you look at this under the microscope, there's, again, just like we talked about, several different variants of dermatofibroma. Well, there's several different variants of this lesion as well. They give you, there can be one that's comprised mostly of spindle cells, like you see here. And there are others that can be comprised of larger, more epithelioid cells. And we've got some of those larger, bizarre epithelioid cells at the surface here. So these are probably the histiocytes, maybe fibroblasts that become malignant. And it's very common to see mitotic figures in these lesions. Usually you'll see abundant mitoses, and they usually are really quite atypical. They usually have multipolar, tetrapolar morphologies to them. Some people refer to the mitotic figures as looking like lumps of coal. I don't really see, maybe up here, there might be one of these. Yeah, here's one of these really large, bizarre cells up here. Maybe we'll find one or two of these in mitosis down here in the bottom. That's probably that's a mitotic figure there. There's probably another one over here. So if we were to scroll around this thing, we'd probably see some of these bizarre mitotic figures, which are very characteristic. So when you just see something like this, it's a poorly differentiated malignant spindle and or epithelioid neoplasm. The differential diagnosis includes three classic entities histologically in dermatology. Now, if you get into soft tissue pathology, there may be more, but from our perspective, what you need to know, what I use every day when I look at these, is the main differentials are malignant melanoma, which can do this on occasion, squamous cell carcinoma that becomes poorly differentiated, and then this lesion, atypical fibroxanthoma. So those are the three. Some people say, well, what about leiomyosarcoma? Well, that's super rare, and no, it usually doesn't look like this. Usually you can see obvious areas that look like smooth muscle bundles in that. So yeah, it can do this on occasion, but it's very rare to do it. Angiosarcoma, very rare to do this. And again, you get the staghorn vessel. So when you're looking at a solid lesion that's got this poorly differentiated malignant spindle and or epithelioid component like this, those are the three things to remember. You don't need a long differential. In dermatology, the longer differential, the less you know. So it's something to keep in mind, but no, those are the three main ones that you need to think about. So we have a panel of stains that we apply to this. We would do a cytokeratin, a stain for melanocytic differentiation, such as a SOX10, and maybe we do one additional one like an S100 protein, although this lesion will have some S100 protein positivity in it. So that's not as good of a stain. SOX10 is a better stain. And then for the actual fibroblasts and histiocytes themselves, CD10 is a good marker. And CD10 will stain other lesions. But this lesion, it stains very dark and very diffuse. So when you maybe do, it's negative for cytokeratin and maybe negative for SOX10, but it's strongly positive for CD10, that's the diagnosis then. You can make a definitive diagnosis. And we'll often do a CD68. That can be still it's variably positive, pro-collagen 1, variably positive. Those are the stains we used to use. But we really like, in our laboratory, CD10 as a confirmatory stain for this entity. And it's really nice. It works well. And you need to use it in context of the other stains as well. Now, there are some other variants of atypical fibroxanthoma. There's one that can give you a lot of osteoclast-like giant cells. There's one that can give you a lot of foamy cytoplasm. It can look like a xanthoma. There's some that can give you a clear cell type. So there's about 5 or 6 different subtypes of atypical fibroxanthoma. And so there's one lesion, one type variant that can actually give you some cytokeratin positivity. And some people refer to those as carcinosarcoma because they still have a carcinoma-like component to it. In fact, some people think that the way this lesion develops is it is basically just a very, very poorly differentiated squamous cell carcinoma that then turns into this lesion. I'm not sure that's true in all cases, but perhaps in some cases it might be. These lesions usually come up relatively quickly. 3 to 4 weeks. They kind of come up rapidly, a little bit more rapidly than a melanoma or squamous cell carcinoma. So, and it looks like a bleeding lesion that's ulcerated on the head and neck area. So that's basically the diagnosis there when you're dealing with atypical fibrous xanthoma. Now, gigantic atypical fibrous xanthomas, when they get really large and deep and diffuse, then just by convention, over the last few years, some people have said, well, we're going to call them when they get giant and get deep, we're going to call them pleomorphic dermal sarcoma. It's the same entity. And just so you'll know, if you go back in time, the soft tissue pathologists, and God bless them, you know, they really need something to keep themselves occupied. So what they do is that they write papers and rename things every few years. And so, you know, Dr. Chris Fletcher's, he's really one of the world famous guys on this. He writes, you know, wonderful papers, but he's commonly giving relatively new entities, defining new entities, taking people, things were called things, one thing for years, and then he gives them a new name and adds new information to it, and then they gets in the literature. And so a few years ago, some of these soft tissue pathologists said, well, you know, this is a malignant neoplasm fibrohistiocytic differentiation, but it's big and it can metastasize, and atypical fibrous xanthoma usually doesn't metastasize, and let's give it a new name. Let's call it a pleomorphic dermal sarcoma. And I personally don't like that term as much because it doesn't say anything about the differentiation of the neoplasm. You can get a pleomorphic dermal fibrosarcoma, because fibrosarcomas can be pleomorphic. They can be in the dermis. You get a pleomorphic dermal angiosarcoma. So I don't like the term just sarcoma, dermal sarcoma. That doesn't tell me very much. So I'm not a big fan of the term, but still it's out there. You should know what it means. It's basically just a gigantic atypical fibroxanthoma that actually then can metastasize and cause more problems in a smaller, rapidly developing, superficially situated atypical fibroxanthoma. So just think of it as a big, deep atypical fibroxanthoma. And years ago, what we used to call those was malignant fibrous histiocytoma, but they decided they don't want to use that name anymore for some reason or another. I actually like that term. It's malignant, it's fibrous, it's fibrohistiocytic. It tells you what the differentiation is. So I think it's a better name than pleomorphic dermal sarcoma, but it's a fad. Everybody jumps on the bandwagon. Everybody calls it that. And so that's what we're calling it today. Probably if you wait around another 10 years, just like the weather, it's going to change and somebody's going to go back to calling it something else. There's also a lot of sort of use of molecular pathology in the soft tissue world to diagnose cancers and soft tissue neoplasms. So some of these are being named now on the basis of what their molecular pathology shows. I don't really like that either, being a morphologist, but nevertheless, just so you know, this is an example of a pleomorphic dermal sarcoma. And this was a little metastasis of one of the lesions, or a local recurrence of one of the lesions. And the reason we called it that was because it was deep and it recurred. And it was basically, you know, something that it didn't have an epidermal component, it didn't have a superficial component like the other. It was just a deep atypical fibroxanthoma, basically. So nothing special about that. Just realize that's basically what we're diagnosing these as. Okay. Shifting gears now, we have a biopsy now taken by punch technique, and it's from volar skin near the finger probably, and that's the most common location of these lesions. And when you look at this lesion, it's got again, notice it's a process that's going on in the dermis. So we're dealing with tissue that's involving fibroblasts, histiocytes, things like that nature in the dermis. And here we've got a lot of myxoid change to the lesion, okay? So this isn't an acral site. It's fibroblasts in here. So these are fibroblasts and perhaps some histiocytes, and it's got a lot of myxoid change to it. So guess what the diagnosis is called here? It's called a cutaneous acral fibromyxoma. Fibro, again, with fibroblast, myxoma with mucin. So it's superficial acral, superficial, relatively superficial, as opposed to being deep in the soft tissue, et cetera, acral fibromyxoma. So that's the name of this entity. And so just realize, and you probably aren't going to encounter these very frequently. I don't think the board examination is going to expect you to diagnose this. It's more of a clinical perspective. These people usually present with some kind of a swelling in the distal digit, and it's usually not painful. It's usually asymptomatic. Somebody takes a biopsy of it to make sure that it's not something like an aggressive digital papillary adenocarcinoma, which is an aggressive lesion. And then lo and behold, it looks like this. So it's basically abundant mucin in an acral location with fibroblasts. If you get abundant mucin with no fibroblasts, or basically it's just a few scattered fibroblasts that may be just a cutaneous myxoma, if you actually do a shave biopsy of the distal digit overlying a joint, you may get abundant mucin there that may have a small little fine sort of delicate lining at the periphery. That's basically a digital mucus, quote, cysting, quote, which is not really a cyst at all. It's basically a contiguity of the joint space with this mucin that gets deposited. And it's mainly due to people that have osteoarthritis. They get a bone spur. The cells that produce the hyaluronic acid in the joint space produce a collection of that same hyaluronic acid mucinous material, and it forms a small little skin-colored bubble in the skin. But this lesion's actually got fibroblasts with it, and this is actually a neoplasm, as opposed to that, which is just kind of really a deposit of mucin due to fibroblasts that are producing too much hyaluronic acid. So this actually is an entity per se itself. So you can see it's not involved in the epidermis. It's basically kind of a little dermal nodule, and when you biopsy it, it looks like this. It's a pretty classic example of that. Okay, another entity. Now this one might actually be on your board examination. So this is something you do need to know. This is they did probably a punch of this thing. They probably just punched the whole thing out. Notice that it's a very well circumscribed aggregation of these cells that have this pink cytoplasm at low magnification. And as you go to higher magnification, it's got all of these little individual clefts between these thick pink hyaline, they're not really keloidal, but they're these thick collagen bundles here with these fibroblasts. Almost looks like kind of wood. It almost looks like a splinter if you cut those in cross section. You see the xylem and phloem. It looks a little bit like that. And some people have talked to us about being analogous to grain of wood. So this is a sclerotic fibroma. So it looks like a fibroma here. It's got an increased number of fibroblasts, and there are individually sclerotic collagen bundles. So it's a reasonably good name. And this entity, of course, has been associated with Cowden syndrome. So you need to know about this and Cowden syndrome and where all the various entities that you can see, the neoplasms, other things to be associated with Cowden syndrome. Dr. Ron Rapini was one of the guys, a good friend of mine, that was involved in writing this up a number of years ago. So we like to give homage to our individuals that discovered and wrote things up. So you're almost certainly going to get this on the board examination, and you should get it right because it's very characteristic. It's got this beautiful sort of almost, again, grain of wood-like pattern with fibroblast and sclerotic collagen. Usually when we see sclerotic collagen, we see a decrease in the number of fibroblasts. In this lesion, you actually do have fibroblasts in there as well. So this is a sclerotic fibroma, very characteristic classic lesion, and hopefully you'll all get that right when it appears on your board examination. Okay, different entity here. We're still in the category now of benign fibromas. So we're still in the fibrohistiocytic category. And you see this is a small little papule. As we go to higher magnification, this is going to have a very characteristic morphology to some of the cells here. And some of these have this, they're multinucleated, and they almost have kind of a little floret morphology to them. The individual nuclei are not really strikingly atypical, but there's some pleomorphism between these cells. They vary in size and shape. Some are really large and multinucleated with these large dilated blood vessels and this thick keloidal, well, not keloidal, but it's thick, almost kind of sclerotic collagen. So it almost looks kind of like an angiofibroma, but you've got all these pleomorphic cells in here. And these are almost certainly, again, fibroblasts primarily. There may be some of them that are histiocytes too, but they're definitely fibroblasts primarily. So this is an example of the so-called pleomorphic fibroma. And basically it's a benign entity. It's got so this is the fibroma part, and these are the pleomorphic cell component of it. So pleomorphic fibroma. And there are several different so-called pleomorphic tumors, if you will, that we see in dermatopathology. You have pleomorphic leiomyomas. You get pleomorphic angiofibromas, fibrous papules. You can see some of these pleomorphic cells in there. You get this pleomorphic lipoma, where you see these same types of cells in here. So there's about 5 or 6 entities that give you these very classic multinucleated, large pleomorphic fibroblast cells within them. And it's sort of a family, if you will. It's benign. It's not cancerous. doesn't progress to cancer. Even the very atypical pleomorphic lipomas, they tend not to progress to cancer either. Rarely they can, but this almost never really does. This is just a benign histologic sort of gee whiz entity. And if you just look at a low magnification, it looks like a little benign sort of fibroma or maybe weird angiofibroma. You get a high magnification, say, whoa, it's got all these pleomorphic cells in here. So just realize that this is just a benign variant of one of the fibromas. Okay. Now this is another entity that's kind of curious. Unfortunately, it's a superficial shave biopsy. And yeah, it's just hard to see a lot when you get something that is just superficial, but we actually were able to render a diagnosis in this case. I'm not sure how we were able to really do that. But you can see that it's got these numerous blood vessels here, and it's got these large sort of cells. They're not really histiocytes. They're probably, there's like an angiomatous component, and there's this histiocytic component. And they're multinucleated. So this is what we call multinucleate cell angiohistiocytoma. It'd be nice to have had a punch biopsy of this, but we can see what the characteristic features are. You get these are probably histiocytes, but some of these may actually be multinucleated large endothelial cells, actually, interestingly enough, that develop in this lesion. And this usually presents as kind of a cluster of these brownish papules. They're often seen in middle-aged women. Here you see the brown, reasonably brown color, as there's some epidermal hyperpigmentation. And they usually kind of occur almost in a little cluster or agglutinated fashion. And kind of the key to the diagnosis is recognizing the vascular component. It almost looks like a hemangioma here. And then you start noticing these multinucleated histiocyte cells associated with that. So if you see what looks like an angioma plus multinucleated histiocytes, think about this multinucleate cell angiohistiocytoma. Pretty rare entity. Unlikely to encounter this on a board examination. As a dermatologist, you should know what it is. Anybody's going to go into dermatopathology, you definitely need to know what it is, but at least from the standpoint of the board examination, a little bit esoteric for that, probably not going to get that on the exam. Here's another one. Again, you might possibly hear about this. This is also another benign neoplasm. You see low magnification. Very, very symmetrical, very well circumscribed. If you go to higher magnification, you can see it's got all of these epithelioid cells in them. Now, what do we mean when we say epithelioid? That means basically it looks like an epithelium. So these cells look like they're kind of really closely opposed to one another, almost like a squamous cell. So that means that it looks like cell of an epithelium, but it may not be an epithelium cell. So what kind of cells can look like an epithelium, but they aren't epithelium? Well, we see vascular lesions do that all the time. Epithelioid angiosarcoma, for example. There's an epithelioid hemangioma that can do it. Histiocytes. Histio means tissue, so tissue cell, and they can sometimes then look kind of epithelioid also. And they can, look like this too. Fibroblasts can be epithelioid. So this is another lesion that's in the fibrohistiocytic category, and the cells are epithelioid. They don't look exactly like the cells we saw of that dermatofibroma. They don't look exactly like cells of a granulomatous process or something like that. So this entity has been termed epithelioid cell histiocytoma. And the way to think about this is basically it's analogous to a dermatofibroma, only it's got this epithelioid cell morphology to it. And if you stain this, it'll stain positively with both CD68 and with factor 13A. So it will highlight with those markers. And that's just, again, kind of another interesting variant. And you can see it kind of looks a little bit like a dermatofibroma. It's got the epidermal hyperplasia overlying. It's a little crust there. And it's not really a classic DF, but it's kind of, think of it as basically like a dermatofibroma, but it's just got these epithelioid histiocytes and fibroblasts. Here you can see quite a bit of mucin in the stroma, which is kind of interesting. So you don't usually see that in a dermatofibroma either. So it's just an interesting variant. Again, a little bit esoteric, probably won't encounter on the board examination, but it's worth at least knowing about. Okay, here's another one that you might encounter. I don't know the board examination will ask you about this either, but it's another variant of a fibrohistiocytic neoplasm. And at low magnification, it looks very much like a dermatofibroma. It's got the overlying epidermal hyperplasia. It's got a proliferation of these cells in the dermis that have kind of the spindle morphology to them. And it's got some key little collagen bundles there. You say, wow, that looks a lot like a dermatofibroma. But then you start looking at it and say, well, look at these other areas here. This almost looks like a smooth muscle tumor. It's got some fibroblast and histiocyte-like cells up here. It's got the collagen trapping. It's a small papule that's kind of well circumscribed, but it's got these cells that almost look like muscle admixed with the cells that look more kind of like fibroblasts and histiocytes. So how do you put those two together? Well, you got something that looks muscular, muscle, smooth muscle, and you also have more of a fibrohistiocytic component. Well, that's basically kind of a hybrid between a leiomyoma and a dermatofibroma. We refer to that as a dermatomyofibroma. And basically, that's a good way to think about it. Think of it as kind of almost a dermatofibroma that's just got a lot of myofibroblastic differentiation in it. So the myofibroblasts are so predominant that it almost looks like they're forming smooth muscle bundles here. So it's almost really kind of a combination, if you will, of a leiomyoma, smooth muscle leiomyoma, and a dermatofibroma. So this is a so-called dermatomyofibroma. So a benign lesion, nothing to worry about. Just another example. And here, instead of just having only fibroblasts and histiocytes, you've got myofibroblast plus histiocytes forming this lesion. Okay, switch over to this. And this is a lesion that is on volar skin. And this is one that you will encounter. And this is one that I think would be fair game on the board examination. I used to give a talk at the AAD on fat and bone and soft tissue fibrohistiocytic neoplasms. We'd always include this because this is a lesion that you do see. It occurs as usually a sort of a subcutaneous feeling or deep dermal nodule on volar skin. Differential diagnosis might be some kind of a metastatic lesion, something like this. You take a biopsy, like usually a punch or an incisional biopsy. A shave biopsy is not going to get deep enough. And it's got these nodular aggregations of these same kind of fibroblasts and histiocytes, and they're actually now forming these collagen bundles in here. So this is a collagen bundle cut longitudinally. These are cut cross section. And this is what's known as a fibroma of tendon sheath. It's in the same category as a Dupuytren's contracture, basically plantar fibromatosis, the fibromatoses. So this is in the category of the fibromatoses. So they all look like this. And basically, they're sort of in the same spectrum as giant cell tumor of tendon sheath. So if you get giant cell tumor of tendon sheath, you get these large osteoclast-like giant cells and osteoblasts. Initially, they kind of gradually go away, and they kind of turn into this fibrous tissue, as you see here. So you can kind of think of these as all being in the same spectrum. Giant cell tumor, plantar fibroma, plantar fibromatosis, Dupuytren's contracture, Peyronie's disease, torticollis. These are all desmoid fibromatosis. These are all in the same category. They're a family of entities, all associated with these fibroblastic proliferation with collagen that gets formed in them. And sometimes you get the cells that are analogous to the bone-forming cells, and sometimes you get mostly these fibroblasts and fibroblasts primarily that produce these lesions. And this is Dupuytren's contracture, plantar fibromatosis. They all basically look the same. If you get something like a desmoid tumor, those lesions can actually be very, very deep. Those things can get into the brachial plexus. They can, cause all sorts of problems there. So if you get that, you need to do an MRI, a scanning technology to see some kind of a scan to see how deep these things go. Beware of going in and trying to cut those out because they really can infiltrate deeply into soft tissue. Okay, this lesion is very interesting as well. This is one you very well could get in on the board examination. And this is a lesion that, again, I'm not sure we really totally know exactly what the differentiation is on this thing. But this is occurred in a child. And you get these small little whorls of these fibroblasts that go, usually they're down in the subcutaneous fat in the lower dermis. And these things present as a skin-colored papule or maybe a little plaque. They're asymptomatic. They're usually seen in very young children. And this is a nice example of the so-called fibrous hamaratoma of infancy. These little almost whorls of these little fibroblasts. They often have a little bit of a slightly mucinous stroma to them in my experience. It can give you this eosinophilic collagen as well. Sometimes though you get a little basophilia like you see here with a little bit of mucin, and there may be a few inflammatory cells associated with it. But when you see these little small little aggregations of these individual spindle-shaped cells with collagen and these little small aggregations down in the subcutaneous fat, think of fibrous hamaratoma of infancy. It's not DFSP. It doesn't look anything like dermatofibrous protuberans. It's not smooth muscle. These cells are really fibroblasts. They've got these sort of blunt cigar-shaped like nuclei. They don't have the delicate S-shaped spindle-shaped nuclei of a neural lesion. They don't have the angulated, jagged, bizarre features of, say, a histiocyte. These are really more fibroblasts that are forming these little small aggregations of these collagen and fibroblasts here. So fibrous hamaratoma of infancy. In that case, it's a nice, beautiful example of that. Okay, this, another lesion from near volar skin, and they were actually able to get this on a shave biopsy. You know, a lot of times you can't because these things are situated more deeply. Look at this piece over here. So again, notice that the epidermis is normal. This is a dermal-based nodule. And here we've got these large cells. They have multinucleated multinuclei to them. They're clustered nuclei in here. And these kind of look like the cells if you're looking at a bone, for example, of osteoblast, and then maybe if you get these larger multinucleated cells, more like osteoclast, like you see over here. So this is a giant cell tumor of tendon sheath. That's what it's called. And these are also in the family of the fibromatoses. If you leave these things alone long enough, a lot of these giant cell lesions will kind of gradually go away. And then you're kind of left with very much what we saw in that plantar fibromatosis. So this is in the same, again, family of these fibromatoses. But notice you've got these epithelioid cells, you've got the multinucleated cells, you've got the osteoplast and osteoclast in the lesion. This is a classic example of giant cell tumor of tendon sheath. Some of these can give you some more foamy histiocytes associated with them. You can get some that can actually have some hemosiderin in them. But if you see a dome-shaped dermal nodule on volar skin that's got these epithelioid cells in some areas and the osteoclast and the large multinucleated osteoblast and osteoclast that we just showed you here, you should think about this entity. And they almost always occur, like say in the palm or sole, your volar skin. Okay. This is one that you probably would not be able to diagnose if you didn't have a little bit of information on this. But and you should know what this lesion is. I'll tell you in a minute, but you can see that in low magnification punch biopsy, you can see there's some fat here and there's some collagen that seems like it's kind of dissecting all the way down and going diffusely into the subcutaneous fat. So basically, this is not normal. Normally, if you have dermis and then you have fat, well, it kind of becomes a nice little transition zone here. Here you've got these big, thick, ropey collagen bundles that are going all the way down into the fat, all the way to the base. And when you see something like this is what you see in a connective tissue nevus or in a collagenoma, for example. In some cases, you really don't even see the fat. You just see these thick, ropey collagen bundles that are kind of present diffusely all the way through the dermis. And it can be kind of hard to appreciate. It can kind of almost look like normal, thick dermis in some cases. But if it goes into the fat like this, you can really suspect the diagnosis. And this is, if you were to see a biopsy of a shagreen patch, if somebody has tuberous sclerosis, it can look very similar to this. So this could be seen in somebody that just has multiple collagenomas. And it could be somebody just has a single one of these lesions, or it could be seen with somebody that has tuberous sclerosis. So just notice the large, thick, ropey collagen bundles. You still have a few fibroblasts here associated with it, so it's not really sclerotic collagen. It's just kind of increased thick collagen that's present diffusely through the dermis where it really shouldn't be. So that's what you see in a connective tissue nevus, collagenoma, or in a shagreen patch. They all pretty much look pretty much the same. Okay, nice example of this. Okay, now look at this. We've got a biopsy here. This wasn't taken by someone with the having a faint heart, if you will. This is somebody that actually took out a knife and fork and took a nice deep biopsy. And so this person presented with a dermal subcutaneous nodule. And a lot of times you think of something as subcutaneous, and it's really not. We see dermatofibromas that are a little on the deep side, maybe the lower dermis, whatever, and then get sent into subcutaneous nodule. Well, this really and truly is, it's beneath the subcutaneous. It's not really even subcutaneous. This is in the fascia. So this was an incisional biopsy. You can't do a punch that goes this deeply. It just ain't going to get there. You got to take something like a knife and fork, scalpel biopsy, and take it and try to cut out this entire thing. And they probably thought this was a cancer. So that's why they cut it out. And you can see that even though it's deep, it's, pretty big, but it's not giant. And it is well circumscribed, and it is very symmetrical. So we're going to higher magnification, and it's got all of these spindle-shaped cells here. Again, fibroblasts and histiocytes with this marked mucinous stroma. It's classic for this entity. And this is a beautiful example of so-called pseudosarcomatous or nodular fasciitis. So what's happened here is that there's been some type of traumatic insult. Usually it's blunt trauma, somebody gets kicked or hit with a baseball or something like that, and this lesion develops usually in a relatively short period of time thereafter. It starts growing and it doesn't stop growing, and then it turns into this nodule, and everybody says, oh my God, this person's got a sarcoma, and they, take a biopsy of it and it shows this, and sadly enough, sometimes it gets overcalled as a sarcoma, but it's not a sarcoma. This is just a reactive proliferation, and the key to the diagnosis is this prominent myxoid stroma that develops. This lesion occurs quite quickly, and you may get some mitotic figures in here. You may get some slightly atypical cells, but usually you get some inflammatory cells like you see here, and the cells usually are not strikingly atypical. So if you get an occasional mitotic figure, that really doesn't mean that you're dealing with a malignancy here. So these lesions, even though they're deep and they can be pretty big, they tend to be really well circumscribed, and you biopsy and it shows this classic finding that you see here. Fibromucinous stroma, increase the number of fibroblasts, most of them typical in appearance with some inflammatory infiltrate as well. So the important point here is to make sure that you don't overdiagnose this as a malignancy. Now, there are reports of people that really do get injured and really do develop sarcoma after that. So sometimes these lesions can actually sort of turn on, if you will, a neoplastic spectrum. And there are rare cases of these lesions actually truly degenerating into sarcoma, but it's most of the time these lesions just kind of go away on their own. But they can do that. There are all these stories, people getting kicked in the head by a horse, and then they develop a true sarcoma, after that. But that's rare. Most of the time it's this entity, and it's just overdiagnosed as a sarcoma. Okay, the last one we're going to end up just like we started off. So we started off with dermatofibroma. So we're going to end up with this last lesion, which is a variant of dermatofibromas. So we've seen several variants of dermatofibromas today. We've seen the ankle type, the deep cellular type. We've seen the classic nodular fibroma type. We've seen the pseudosarcomatous fasciitis, which is kind of in the variant of that same sort of pattern. And then we've look at this type right here, which is what's called a cellular dermatofibroma with extravasated erythrocytes, kind of a aneurysmal fibrous histiocytoma variant of dermatofibroma. And again, these lesions give you a lot of extravasated erythrocytes, and they can give you these large angulated histiocytes that have engulfed hemosiderin. So lots of siderophages, lots of extravasated erythrocytes here. And so this is just another variant, kind of, if you will, of a cellular dermatofibroma that's got this angiomatous-like component to it. So it's basically a hemosiderotic aneurysmal fibrous histiocytoma variant of a dermatofibroma. Totally benign. These lesions sometimes get sent in as rule out malignant melanoma because they can be pretty dark. They can be, black almost, because you got all this extravasation of erythrocytes and siderophages. Notice this very large siderophage there. That's almost kind of beginning to look a little bit like one of these so-called dermatofibromas with monster cells that we talked about here. But this is just a total benign variant of dermatofibroma. And notice again the very thick keloidal collagen bundles at the periphery here, as we see with dermatofibromas quite commonly. So just another variant. Don't overcall it as cancer. It's not malignant melanoma. It's nothing to worry about. Patients don't need to be freaked out about this. If you get back to diagnosis, you don't have to do a wide and deep excision. So just realize this is just one variant of a DF that can sort of look dark and kind of look ugly clinically. Okay, so that's a nice overview of many of the dermal fibrohistiocytic neoplasms that you're likely to encounter. It's obviously not all of them. There's a few others that we didn't talk about today, but that's a good overview of these. And I think if you know those, you're going to be in pretty good shape for the board examination. They're not going to spend a lot of time on these, not trying to make you out to be a soft tissue pathologist on the board examination. So they're not going to expect you to know everything there is to know about this. But if you know those entities pretty well, DF, giant cell tumor, those lesions we talked about, you're going to be in pretty good shape. So thanks for your attention. And we got another lecture coming up next week, and we'll see you.